Welcome to Caring.
Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well.
Caring Well. Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well, a Middleton Pediatrics podcast where we explore topics to come alongside you as you care for your child and to help your children flourish. Today we have a conversation with Dr. Michael Keating, a pediatric urologist. He talks about so many different things, a lot of different conditions, common ones and some that aren't so common, and things that really are just about children and healthcare in general. So I think you're really going to enjoy things he has to say. Let's join that conversation now. So Dr. Michael Keating, welcome to Caring Well. I so appreciate you being here.
Oh, thanks for inviting me, Michael.
Yeah. As a way of just beginning, I'd love for you to just introduce yourself, your area of medicine, and how you got into that.
When I was a boy, I found out at a young age I'd been an athlete like you were, Michael, and I kept getting hurt, and I was diagnosed with a condition called hemophilia. And so I spent a lot of time in the hospital when I was, a teenager, and because I was getting hurt all the time and I didn't really, I was told not to do anything. That's when you do things even harder, right? But I saw what, healthcare was about, and I experienced it firsthand. And I was always the kid anyway in the neighborhood who would, take out the other kids' splinters and my mom's eyelashes when she, I was the one that did all that. So I always knew I would be in
Destined,
medicine
yeah.
and wanted to be a physician. After going to college, I actually didn't get into medical school for a year or so, although I had very good grades coming out of college. And so I went and worked in a hospital in Columbus, Ohio, and I was a nursing assistant for a year and a surgical assistant for a year while I reapplied. And then I got accepted to medical school. And while I was in medical school, I thought I wanted to be a general surgeon, I wanted to be a family practitioner that did everything somewhere out in an outpost, delivered babies and do appendectomies and take care of kids and older people. But I realized I could see where medicine was going into the world of subspecialization. And those days of, the local town doc doing everything were pretty much on the way out. So then I thought, well, general surgery. I went and trained in general surgery. And the problem with general surgery then was, to me, it seemed like a daunting amount of knowledge. And where do you, saw that breaking apart in subspecialization. So my future wife said, the only time you were really the happiest was in urology. And at the time, and the urologists were really nice guys and or gals, and they had good senses of humor, and they let me do a lot. And there was a new field called pediatric urology, and I wanted to take care of children. I have 4 of my own, and I've always used to babysit. I was like the bigger kid that all the little kids kind of Pied Pipered behind. Uh, and so, to me, that was great because it was an open field, right? And I was fortunate to be able to train with some really good people up in Boston. And, it was well matched to my desire to take care of children and my technical abilities, I'm kind of an artistic kind of guy. So what I do basically, I do a lot of plastic surgery type things on patients in addition to the medicine. The other thing I liked about urology was that it was a balance of medicine and surgery. And so my world is not only filled with the surgery, it's also filled with the medicine, whether it's urinary tract infections, bedwetting, those other things that are very interesting. So I've been doing it now for some time. I've been a physician since 1980, and I've been a pediatric urologist. It took 7 years of training to do what I do. So I've been doing that for a while, but I love what I do, and as long as I still have game, I'll continue to do it. And I promise I still have game.
I bet.
So
So let's talk about some of the common things you see, some of the
Sure.
common things that make it to your office or to your operating room.
Well, the most common case would be circumcisions. We did, the last year I looked, we did over 900 circumcisions of various types. Undescended testicles, these are little boys whose gonads are not dropped, occur in 1 in 100 boys. So we fix probably now 200 boys perhaps a year with that condition. We'll do a lot of hernias and things of that nature in the groin. I think that's more of the standard thing. My partner is a robotics expert. And when he came, I told he was specially trained in robotics, and I had done some robotics training. But my feeling was, I told him, I said, if you come to join me, I said, anything you can do robotically, I'm going to send to you. And so, and he's really good at it. The first time I saw him repair a bladder that was backwashing or refluxing up into the kidneys, and he did it robotically, I said, I'm never going to do that operation again because it made a lot of sense, and he did it, in a very expedient and safe manner with a good outcome. He also fixes blocked kidneys. So I see a lot of babies who are born prenatally with urinary tract abnormalities, such as a blocked
So these
kidney,
things are
for example.
diagnosed before the baby's born. And so
Yes.
you've already met the family.
Met the family. I like to meet the family. I like to talk to them. I like to reassure them. The large majority of children that are born with an abnormality diagnosed before the babies are born do not ultimately need me, but I think my major role there is to reassure them and tell them that if surgery becomes necessary, you'll be in good hands. But I also tell every family, I said, your baby's in bigger hands than any doctors. And so, for example, earlier this week, I do a lot of the smaller babies, the microsurgery, and Pablo, if he's around, will help me, Dr. Gomez. But I did like a 2-month-old baby just Monday night who had a blocked kidney. And, the baby went home the next day. I have another baby. I'm doing a little baby tomorrow that unfortunately has kidneys that don't work well, but they're so big that we can't do the other care required. So this baby's just a few, days old, but we'll be taking those kidneys out so we can hopefully, get the baby to transplant ultimately. And the medicine's gotten very sophisticated. um, those babies historically would never have survived. But if their lungs are good enough, we can get them as a bridge from not having renal kidney function early on to about 1 year of age when they're big enough to transplant. And nowadays, when I was a younger physician, I mean, you knew who the transplant kids were because you'd look at them and go, transplant kid, transplant child, right? Nowadays, the medicine's so good, you can hardly tell. It's fascinating. And it's been really, really fun to work with it and to watch it, and I'm gonna miss it because I'm really excited about what's coming next, to be honest with you. Um, and then, I'll get home and I'll usually, unfortunately, I'll have phone calls and like you, I mean, and I tell my team, look, medicine's not a 9 to 4.
Right, right.
If you're really all in on it, it's a 24-hour gig, which is okay. Um, you try to I have 4 children, and I think one of them told me, said, "Dad, how did you do that?" Because you go to the office like you do, and then you go home and your children want you as much as your families, and it's hard sometimes to, because I'm all in when I see my patients. Then you gotta go home and you hope you're not tapped out, that you still can't give more of yourself, and you have to try to do that, so.
Well, tell me about your clinic days. So what do you see? What are the common things you see in clinic? And as you talk through some of these things, I'd love to hear, thinking about who's listening to this, which are parents of our practice, and
Right,
talking about
right.
some of these common issues. How do you explain it to them? Uh,
Okay. So let's talk about bedwetting.
okay.
So for surgeons, bedwetting is a non-surgical issue, and I actually get
Thank goodness.
I get
Yeah.
a kick out of taking care of bedwetters, and I've trained my staff to help me take care of bedwetters. So bedwetting is it's frustrating and it's a nuisance and everything, but I think the most important thing for the parents that are listening is that a lot of kids that bedwet, they really have 24-hour a day toilet issues. When you talk to them, they're often boys and girls who wait too long to go to the bathroom. They may be at school where they don't like their toilet. They may be trying to get to the next level on their game, whatever the deal is. If you're in your bladder's a muscle bag, if it's sitting there wanting to go and you don't let it, it's doing exercises, it's getting kind of jacked up. And then you ask them, is your child a deep sleeper? Yeah. Well, guess what? if you're a deep sleeper and you go to bed with a high tone bladder, you're going to wet the bed. So that's why a lot of the children I've seen have already had the medications that might be given, and they haven't gotten any better. That's because the wetting is just a nighttime manifestation of a 24-hour form of bladder immaturity or bladder dysfunction. In addition, and I think this is extremely important, many of these kids have an element of constipation. So, and I tell parents, look, the same muscles that hold on to your potty as your pooper hold on her. When you're a retentive kind of a child, you don't selectively say, I'm just going to hold on to number one. You're globally tight bottom. And now there's only so much room down in your pelvis. So you've got your bladder in the front. And if you've got a big bowel movement behind it, that might be the night that you wet, because a lot of these guys or gals, they don't wet every single night.
Right.
Well, why would you wet some nights and not wet other nights? So what I do with a lot of children, first of all, I think it's important as a pediatric provider, when I go into a room, regardless of the diagnosis, if the child's old enough to need to understand what we're going to do or do something, I connect with them and I talk with them, and my first handshake is with them. I think the physical contact is extremely important. But I'll have the children, I'll say, okay, do you brush your teeth every day? And because the first thing that kids learn in their hygiene is brushing their teeth. And they'll say, why? They'll say, yes. I say, why do you do it? And I said, do you want snaggle teeth? No. Do you want buffalo breath? No. You want sugar bugs? No. They get all that kind of stuff. I said, okay, so I'm going to teach you about another part of your body. Are you ready? And I'll say this, and I'll hold their hands. I said, I want you to hold my hands because I've got, you want them to listen. If they look away, say, look at me. I'll say, look at me, because a lot of these kids, they've not dealt with other adults that get into this kind of space, but I want them to also to listen. And I'll say, underneath your belly button, connected to your private area, is a little bag that holds your potty. I said, it's called your bladder. Say bladder, little 6-year-old kid, but they're smart. These little kids are smart. And especially the older kids, it's much easier, but the little ones are kind of fun. And I'll say, okay, and I'll say it again, underneath your belly button is a little bag where your potty sits. It's called your bladder. Say bladder, bladder. Okay. Your bladder is your inside toilet before the toilet in the bathroom. I say, what happens to the toilet in the bathroom if you don't flush it enough? They say it gets yucky. I say, yeah. I'll ask the mother. I said, does he have a brother or sister? Or should she have a brother or sister? Yeah. They'll say, what's the name? I get the name. I say, yeah, you lift up the lid and your brother, Johnny, oh, mom, Johnny didn't flush the toilet. I said, your bladder's the same way, especially in little girls. Little girls start to get urinary tract infections when they start going to school because you've changed their toilet comfort zone. And you ask the child, I'll ask them, do you go to the bathroom at your school? No. Do you poop at your school? Never. Are you kidding? And I tell the parents, this is the kind of kid that's running home at the end of the day to go to their favorite bathroom.
Mm-hmm.
And I said, when you go to school, I explain, you eat your lunch and your stomach tells your colon, hey, you gotta clear out because I'm coming. Well, guess what? That child's in for a long afternoon. That's the kid that's running home to get to the bathroom. And I explained, I said, even if you don't like it, you've got to use the toilet where you're at. I said, you've got to listen to your bladder and take your time. I said, get your legs apart, because a lot of these little kids, they sit with their bums in the toilet bowl hole and it doesn't allow the muscles to relax. And I said, you can't brush your bladder, but you can flush it. And then I have this little motto. I actually used to give pencils, an empty bladder is a happy bladder. So I say, repeat after me. An empty bladder is a happy bladder, little kid, empty bladder. And I said, an empty bladder is a healthy bladder. I have kids that come back.
You need t-shirts.
I should, but yeah. I have kids that come back years later and go, an empty bladder is a happy bladder for some other thing.
Right.
It's so funny, because now I'm at a stage where the fathers will come in and after the discussion about their son or daughter's problem, they'll look at me and say, Dr. Keating, you took care of me like 20 years ago. I go, oh, really?
That's awesome.
What did I do? Did I get it right? Oh, yeah. Yeah, it's a lot of fun. So,
but then you hit two big ideas that we find surprising to families in the office, because they come in for nighttime wetting. And then when the conversation goes towards constipation,
yeah,
or daytime dysfunction, and they're if you bring up constipation, they'll be like, no, I'm talking about nighttime wetting. It's like, I know.
Yeah.
Or if you say, daytime dysfunction. No, I'm talking about nighttime. Daytime, they're fine. But you're highlighting two things that are part of this condition that aren't intuitive to the families.
Absolutely. And then the parents will oftentimes say, well, he's regular. And I say, yeah, well, he is regular, but he's not efficiently emptying. I'd say basically he's dropping off the basement of a skyscraper of poop. And we give the parents I said, I give them the handout, the Bristol stool scale. This was invented in Bristol, England. And it's a cartoon depiction of basically how you're doing.
Right.
And it's very helpful because, and I tell the patient, I say, look, I don't want you flushing this weekend. I want your parents to check those bowel movements out to see how we're doing. And a lot of times the parents call and say, oh, you were right, or whatever. I'll say, okay, we'll give a clean out. And then I'll tell them, if your problem persists, we'll get an x-ray to see if you're really doing as well as you think you're doing. And a lot of times they're not. And the reason this is important is because some of the medicines are directed at relaxing the bladder and helping it hold more and cutting down on the frequency that a lot of kids have during the daytime. The problem with those medicines is that they relax the muscles and they can also relax the bowels. So you're robbing Peter to pay Paul. But this is why kids get into trouble on a vacation. Oh, it's vacation food. No, it's not vacation
Right.
food. You just put your child in
You're not comfortable
in the
there,
twilight zone of toilets and they don't want to use it. That's what happens.
What's your typical regimen? So you talked about some of the problem there, the nature of the problem, the contributors to the problem. Say, what are we going to do to help this child that's having nighttime accents?
Okay, so I work on the daytime issues, and a lot in many of the children, especially the ones. A number of times we've seen people that have seen a lot of other people or other physicians or things have been tried. We'll get an ultrasound and see how they empty. And the reason this is important is because they're basically two bladder pictures. If the ultrasound shows that the patient is emptying all the way, then that's a patient that may just have a small bladder that would benefit from getting more room. And that's where those medications would work as long as the bowels are buffed up. In other cases, you'll see that the child has gotten so good at holding on that they're just going off the top.
Which is the same thing with the constipation.
Absolutely. The
not
picture's
fully
the same.
emptying.
Yeah, they're not emptying at all. So I tell the parent, look, if you got a 1-gallon bladder and you go to the bathroom and you only empty 6 ounces, you got a 6-ounce bladder functionally. And it's surprising how many kids, you'll get an ultrasound and say, well, look, you left behind 5 ounces in your bladder. What? Yeah, I said, the problem with the urinary tract, it's not out there like an ingrown toenail or a rotten tooth. You don't really know if it's going south very much unless you really start to have problems. So, and this is very important. I have had children, a number, who have taught themselves how not to go to the bathroom. And what happens, unfortunately, the bladder, it's like a muscular waffle bag. And sometimes it gets so big that the waffle can't come together to squeeze the juice out of the lemon. So, but there's ways to finesse it. And then actually, you can listen to your child's stream and kind of tell what's going on. In a normal situation, and I do this to the parents, I say, when your bladder's full, if the muscles are relaxed, you would hear this. If you're not going effectively, you'll hear one of two patterns. You'll hear they're just going off the top, or you'll hear this
Intermittent.
Yeah, and they're not relaxing those muscles. So we'll spend time with the children and try to teach them how to relax. And the way that we do it, we used to get pinwheels. They're harder to find, and we'd have them blow out really slowly. But what I try to teach the kids is, look, if you ask a child to pee, they hold their breath and void. But what you want them to do is exhale slowly, like blowing out a candle, and push down at the same time. It's not that easy to do, but it's basically a slowed down version of what a birthing mother would do during birth, which is to and push the baby through the very same muscles that these kids are too tight with if they're not emptying very well. And it's pretty effective.
They can still find pinwheels because our patients do.
Oh, do they?
Yeah, for sure. There may be someone who doesn't do anything you suggest. So that person aside, what are the reasons that someone wouldn't respond to the regimens you've suggested the more difficult cases that
Right.
persist even into adolescence?
Well, I think it's very important, if your child has any other medical conditions that we know about them. I also think it's important that any child that's a wetter has his genitalia checked closely and has his spine checked. It's very uncommon to have a spinal cord abnormality that does not have a cutaneous sign that there's some kind of underlying mischief going on, like some kind of spinal cord abnormality. And we've seen a number of children who, once we turn them around, you're going, "Whoa, nobody really checked." That wouldn't happen in this office, but it happens in offices, and they've done studies, take the wetting out of it, just on the genital examination of young, especially young males. It it doesn't get done in a lot of offices. Physicians assume that if the boy's testes were, quote, down when he was a year old, that they're down. Well, what happens a lot of times is that over time, that as the child gets longer, the testicle and its cord does not there's an abnormality along the cord. And I've sidetracked a bit, but it's tethered the testicle. So over time, the testicle assumes, in relationship to growth, a
Higher
progressively higher
position.
position. And this phenomenon called testicular ascent was only described probably about 15 to 20 years ago. We first saw it in cerebral palsy patients because they were spastic and the muscles of the cord were spastic. And nowadays, I'll see boys and I'll say, "Well, look, these are both down right now, but I'm concerned on this one side. It's kind of tight. So somebody needs to keep an eye on that side, or you need to bring him back in 2 or 3 years so for me to recheck him." And, some of the boys do come back and ultimately require surgery. So different issue, but a wetter needs to be evaluated, especially if, people are pulling their hair out and you're not making any progress. Even in It's rare, but in occasional cases where we can just not get the bedwetting better. Fortunately, most bedwetting resolves by the age of 15. So if you look at, the recruits into the Army, the overall incidence after 15 is extremely low. But some kids still wet, and we'll turn the cards over and do more sophisticated testing, whether it would be a bladder X-ray or an MRI of the spine to make sure we're not missing something. It doesn't alleviate their wetting necessarily, but we've made sure they don't have an underlying serious health issue.
You were starting to talk about testicular issues. And so maybe think about the adolescent male and
Yes.
testicular issues. Talk a little bit about that. I'm sure that shows up in your office a lot.
Oh, absolutely. I think we need to do a better job as physicians and providers of teaching young men how to do self-examinations. The most common tumor in young men and young adults is in the testes. And it's the same way that women are supposed to examine their breasts. Boys and young males need to learn how to do
Yeah, give your
self-examination.
spiel. Give what you tell.
I'll give you a tragedy. We had a 17-year-old fella here a couple of years ago. He was a very successful athlete, was going to sign a professional contract right out of high school, went for his examination, and the examining doctor said, "I feel something in this testis." And the player goes, "I've known about that for a year." By the time he came to me, he had, soon after, he had tumor cancer through his belly and in his lungs. And unfortunately, although that's a treatable cancer with a high likelihood of survival, he
When
did
caught early. Yeah.
when yeah, the bottom line is, there was smoke and nobody was told, so the house burned down. It's the same thing with a condition called testicular torsion. The testicle, for the best description, hangs off the body like a yo-yo on the end of a rope. There's one way to get the blood. It's down the rope with the sperm cord, with the vas, where you do a vasectomy if you want to not have children. And in some boys, it will twist, and it's common. Pablo and I have had months where we've done as many as 15 to 17 boys with torsion. That's one every other day. And guess what happens? The smart boys who've been taught to tell their parents if they have any concerns, we see them early. In fact, I just saw a young man yesterday. He was in high school. He had actually, was it today or yesterday? He was in high school. He had acute onset of pain. He goes to the local emergency room. They had some decreased flow on that side, but he told somebody right away. and we were able to save his testicle. He got shipped in. We have a very good system for that. But it's very common where the boys will sit at home. They'll, worry about it, but they'll hope it gets better because a lot of them have had earlier episodes that did get better. And then by the time they get to my office, I pull down their pants. I'm going, man, when did this happen? 2 days ago. I go, why did you tell anybody? Well, I was embarrassed. I thought you'd have to do surgery. I go, well, if you'd come earlier, I might not have to do the surgery I have to do, but now you're going to lose your testicle. Now, fortunately, if you have one testicle or one kidney, and some kids are born with one kidney, your life expectancy and your function should still be normal because the other one can pick up the action. But we do not do a good job in this area. And I tell my team, no young man, and this starts, age 9 and 10, should leave our office without getting that information. It's crucial.
But is there something specific you tell them about how to do a self-exam?
Yes, I examine them. I say, okay, you go home tonight and you examine your testicles and you can say that the old man checked them and this is my baseline. Now they're going to get bigger, but they never will stop feeling the way they do. And I say, you feel a soft egg and there's that other little noodle in there. That's how it's connected to your body. And a lot of times I'll draw a little picture so they understand. And
You need to put all your pictures in a volume, like George W. Bush's artistic work. You need one.
Well, actually, I've done medical illustrations and published a few things, and I liked it a lot. It just took too much time, but I may get back to it someday. It's fun, but that, that's a really important thing. And if we save one young man's life doing that, it's important. I'll tell you what else is happening. And it even happens in the best emergency rooms is the boys go to the emergency room complaining of abdominal pain. And because they're teenagers, nobody checks their genitalia and the abdominal pain, because the gonad is connected to the abdomen and its contents. A lot of times they'll have pain that projects up and they'll get a CAT scan, no appendix, go home, you're fine. And then the next day they come back and now they've lost a testicle. That's inexcusable. So this is more a message for my provider friends if they're listening, but the parents the same. If your son is complaining of testicular pain or abdominal pain, especially on the right side, ask him if his testes hurt.
What do you think makes a great pediatric specialist?
I think a really great pediatric specialist can make a relationship with the patient when age allows and the parents that you basically become part of the family. They trust you so much because you've been able to communicate with them and bring the medicine down to a level that they can understand and that they know that there's a problem, that you're going to stay committed. Um, and you're there for them. And if you're not there, you have a good replacement for them. I think the scariest thing for a family is when they're cut adrift. And I tell every parent when I get done with my surgery, I tell them, I left that room as if this is your child's last surgery. I talk about circumcisions, for example. If you do 1,000 circumcisions, you have a 1% to 2% infection rate. If you might have a 1% to 2% chance of bleeding. So you're going to have a small group of kids that have problems. And I tell the parents, I said, look, if there's a problem, I said, you'll be upset. I'll look at the dad, you'll be upset and I'll be upset because when you're the surgeon, you want people to come in and say, wow, they really cared and my kid got a great out. That's what fortunately happens much of the time. But where the rubber meets the road is if your child has a problem. And I tell them, I said, look, we'll get over the upsetness. I am going to own it. And I'm going to get us through that. So I think surgeons, especially if they do a surgery, better know how to take care of the complications. And if there's a complication, we're going to take care of it and stay committed. So, but I think the communication is, it's a human thing. You walk into the room and if you're doing well, you communicate, you look in the family's eyes and you take that extra second. I always sit down in every room and the studies, if you sit down, it's almost an optical illusion of
Right,
time, right?
right.
You faked them out. He was in there a long time. Really? He wasn't.
Right.
He was in there less than the guy that came in and just looked at his computer and did all
Stood
that.
up the whole time.
I
Right.
never do any note taking in my rooms. I'm actually fascinated now by the AI ability to take a visit and condense it, and we're trialing that a little bit. That would give me even more time to do the other things I like to do. The paperwork of medicine, I think, is really, can be a little bit of a drawback, but I think we're going to get through that. So I'm excited about a lot of it. But the caring part is that's the secret sauce.
How do you scale that? So there's things you just mentioned about what make a great pediatric specialist that you can say these are deep in my core. This is part of calling, vocation. But how do you get that into a system? How do you scale that mindset?
I think your just your example in front of your colleagues is key. And I've been in positions where there'll be a problem, and I'll say, "Look, we've got to go down and talk to the family, and we need to apologize. I'm not going to do that." I said, "Yeah, we're going to go do that because you have to be totally transparent, and you have to show that you're going to care." And I think it helps. Nowadays, people can go to the website and they can see a little video or whatever. Well, if you're given that kind of thing on the internet, you better be living that in the
Mm,
hospital, and people can see and who the good communicators are. And when they're not, you try to encourage them and work with them. Hey, look, we got to slow down. We got to you know, I listen to you. I listen to my providers periodically and hear their talk. Let's go in and do the wetter. I want to hear your gig. And I'll say, well, they used a couple words. They would have no idea what you're talking about. And we get through all those kinds of things. So you try to groom them that way. But again, it's more of a lead by example. Yeah,
it's
it's totally a lead by example.
it's interesting and sort of lamentable that clinical knowledge is better than it's ever been. It's by no means perfect, but it's better than it's ever been. Technological advancements and all these things, and yet patient satisfaction is not.
Right.
And you and I have talked before just about how trust has even been eroded. So this irony, sad irony, that in a time of greater clinical knowledge and more technological advancement, that patient satisfaction and a lot of it you've alluded to it so well. If someone said, why would that be? It's the human stuff, right? It's the
Right.
it. What about modern healthcare has a tendency to dehumanize and happen outside of a relationship,
Right.
and how do
Yeah,
we foster that?
yeah, it's a funny thing. I think we need to continue to work harder and harder at the non-medical types of things, because the way it's going, it looks like the pure medicine of it's going to be easier and easier to come to conclusions, as a lot of the decision making and the algorithms and presentation, it gets condensed. So you already know. So now, especially if we're given more time and unchained from the paperwork and the more, burdensome, boring things of medicine, we should be able to then do more of the pastoral type of things, where you go in. In our hospital, we've started a thing called compassion rounds, where doctors that are interested in doing it go around and see families, not at all to talk about the medicine condition. We're not even involved in the care, but we're involved in um, the well-being of the family. How you doing, mom? I'm, you know, we have a couple doctors, Dr. Marla Carter, one of our hospitalists, pardon me, intensivists. She's really good at it. She's got a heart. We have a number of doctors whose hearts are just humongous. And they go and they do this periodically. And I think, once I slow down a little bit, I've been involved already, but I'm going to get back to those kinds of things. It's extremely rewarding. It makes you feel good. You know, the first couple of times we did it, I was like, wow, that's really fun.
Hmm.
It kind of puts in the things in medicine that you were fired up about maybe when you were younger.
Yeah,
And
why
then,
you went into it. Do you think physicians, and this is a broad brush question, have changed over the years?
Uh, well, you have to remember the number of physicians has increased so much, so you might be attracting more people that maybe weren't brought into medicine for some of the reasons that you and I have discussed that I think are in keeping with success.
Hmm.
And you can tell, and the other doctors know, the doctors that, are churn and burn, and, you know, they may be good at what they do, but and it's interesting to see, oh, well, that's just the way he is, and, the doctor didn't spend any time with me. Yeah, but he or she's the one. They're really good. Well, okay, now is that gonna work for me? And that works for some people, and it doesn't work for others because other people want not just a good technical surgeon, they want doctors that care as well. So that's what you want to get yourself around, or surround yourself with. Do I think that? No, I think at the beginning people go in a lot of times with that idealistic thing, but then when they really understand what it's about, because I got to tell you, Michael, I think the most important years for me were the years that I spent in that hospital before I went to medical school. Because when I went to medical school, I knew what it meant to clean somebody's bedpan. I knew what it meant to change sheets and dressings and prep patients and everything. I had That's why I think a lot of doctors have gotten themselves a bad rep, unfortunately, because they don't value the people that we work with sometimes. It's not easy to be a nurse. It's not easy to be an environmental, person that cleans those wards. Those people are extremely important to the success of your hospital, to the success of your office. And so we have to value those people. I think that's why a lot of physicians don't really understand how to work with extenders, because extenders want to be valued for what they do. We treat our extenders like colleagues. Now, I understand that they have their life, and they have their life in a little bit more order than me, and maybe they don't have quite the decision-making burden than I do, which is fine. That's what they've opted for. But I totally value them, and that's where the success is. Now, probably they'd say that, well, we start off the school hard knocks because Dr. K is kind of a taskmaster. Yeah, maybe, but that's because I have a standard, and I want you to run with me at that standard and take the ball when I lateral to you, and and carry it over the goal line for me. So yeah, it'll be interesting to see where it all
Do you
goes.
think patients have changed over the years?
I think they're surprised when they see now somebody who really cares.
Hmm.
A lot of times, they've found your practice because people know. Word of mouth is still the best form of advertising. You do a good job, people find out about it. Now the internet and the the ratings and all that stuff, that doesn't hurt either. But you know, uh, patients have been jaded. I don't think we've been helped by the medical legal situation, and but I don't think we've done ourselves any favors because we've gotten away from some of those basic principles.
Is there any way you're a different physician now than you were in your 30s and 40s?
When I was a younger guy, I always called myself the fire breathing dragon because I was trained with people where in the in days past, surgeons were, especially where I trained, were put on a pedestal and they were catered to, and they got away with things that really don't work anymore. I would say when I was younger, I didn't really understand that residents weren't as committed now as I was when I was a resident. And I railed against that and tried to change the behavior, but that was a generational thing. I didn't really understand it. Now I totally understand it. Of course, now, I'm far into the game. I've made all the mistakes in dealing with people, which is probably why I was a CMO for a little while. But um, yeah, I mean, I've seen all the stuff for the most part, or anything that comes now is a spin on something I've seen. So I remember where I've made a mistake in handling it for the most part, and try to do it a different way if it didn't work historically. So in that sense, yeah, and I'm probably a little more laid back. I'm not, an easygoing kind of guy, and I have high standards, but I've gotten better at bringing people along to that level rather than hitting them on the head with it and expecting it. That doesn't work anymore. People don't remember everything that you say, but they do remember how they've been initially handled. And I think there's a lot of merit to that. Uh, and so,
Yeah.
yeah,
You've said a few times that you're hopeful. But what specifically are you hopeful about when it comes to healthcare?
I should talk about Orlando. I would be hopeful that, we could, get everybody together on the same page to do what's best for the children in Central Florida, which might not be fragmenting the care into three different institutions. I understand that hospitals need to have pediatric efforts, and I think each of the institutions does a very good job. And there is some merit to competition, but when you look at, cost efficiency and expertise and the experience that now is divided by three rather than put under one umbrella,
Mm-hmm.
um, it's a shame we can't get that together. I historically, many years ago, I've been in the community for I think 27 or 28 years. A few years before that, I think it was Gerber, one of the companies, had come down and looked at our city and talked about doing a freestanding children's hospital that at the time would have been between Advent and Orlando Health. That didn't happen for whatever reason. Um, and then, Arnold Palmer came into being. And then when the Moores came to town initially, just in a clinical sense, when they decided to build their hospital at Lake Nona, Advent Health had to decide to get into children or, at a higher level. And I think that they've delivered on their promise without question. But, and there's some, the strength of the community. I always tell people the strength of this community is its primary providers because I think we have a lot of really good ones. And we have an increasingly number of very capable tertiary care providers, but it's a shame we can't get it
More
together on
coordinated.
one coordinated effort. So, for example, a lot of children's hospitals, they're the carrot that fundraising is built around. That's fragmented.
Right. Right.
The dollar is now 33 and a third cents between the three organizations because people are confused. A lot of people don't even understand what Advent Health does in pediatrics. I mean, we have a 212, I think, some odd bed hospital. We're a leader in liver transplants because of our relationship with the University of Pittsburgh, which is the mecca for transplant surgery. Um, and we may be starting to do other relationships with other, internationally known children's efforts. But it's a shame that we can't put all that together. I think the physicians would understand the merit, but we'd have to have the administrations understand that and somehow figure it out that everybody could get what they wanted out of pediatric care, but the real winners are the children. And so it'll take leaders like you and maybe me in my old age to, push that envelope and see if we can change things in that regard.
Yeah. If you had a magic wand, I mean, is that what you would, and you had one trick? Is that the trick you'd?
Yes.
Yeah.
It would be one trick. It would be, now there would be, and maybe another way to finesse it where one hospital would be the expert in this area, another hospital would
Right.
be an expert in this area.
But it was still
Yeah,
coordinated.
coordinated and working together. So, for example, when I first came to town, I spent my first 12 years at Arnold Palmer Hospital. I know the physicians. There's some really good doctors in that system. And I know some of the doctors at Nemours, and there's some really good doctors in that system. And so, and then we do work together in a sense, but, it's not the same as all being together where we're really in it for the kids.
Under the same banner, right?
Under the same banner.
Right.
Yeah.
Yeah. Just because I know you and I know you are, you have the authority to answer this question. What do you think makes a great parent?
That's a toughie. I'm not sure I've gotten them all right. I think one of the important things is that the parents need to be on the same page.
Mm.
Now, it doesn't mean that you both have to play the same role. So in my case, I was more of the bad cop,
Mm.
and my wife was more of the good cop. But we knew that. I mean, this was openly. We had our discussions, and we would talk about the kids and make sure that we were on the same page about where we were going, where we wanted to try to direct them. Um, it's a funny thing about children. They're going to make their own decisions, and you're not going to agree with all of them. Um, but what you have to have faith in is that you've taught them the difference between right and wrong and have given them good values. So I haven't always agreed with their decision making, and when not, I've let them know about that, but I still continue to love them, and despite whatever decisions they might make. And I think, and they know I've always been there in case they needed that. So, and there have been times when it's been a little bit bumpy and you have to make some tough calls. I won't get into the details, but I hate to tell the parents out there, but it's not going to end up the way that you think it should.
Right.
And so, and when it doesn't, you have to understand that these kids have to learn to fly on their own. You cannot helicopter them through the rest of their lives. And if they make a mistake, it's not necessarily a bad thing. It's almost temperance by steel, steel,
Mm,
right? I think it's probably why, I've become hopefully a better physician and maybe a better person because I've learned from my mistakes. And I think that's what you want. You want to set a good example for your children, but when they make mistakes, you counsel them about it and you don't crush them. And, you handle them the same way you'd handle, in some instances, you don't want to embarrass them, but you gotta let them know that, "Hey, we're not really in agreement with all this that's going on, and you're making some bad decisions, and let's discuss it and decide where we're gonna, get to." Um, and then after that, you see how it goes,
yeah.
but,
They figure it
try
out.
to be available. I mean, I think communication is the key.
Which
I
is really, I mean, the parallels are so interesting in the sense that it's this context of a relationship, communicating, listening. I mean, it's a lot of, again, it's similar things, and it's because they're both human things, right? Caring for patients, parenting, um, some
well,
transcendent traits.
I had a big family. I had 6 sisters, growing up. I was the only boy, and that was a lot. We had 4 children, and that was a lot. Nowadays, my kids my son's like, "How'd you do that? 4 kids? How did you pull that off?" I think a lot of it was because my wife, she's
Sure.
amazing. But, just do the best you can and and love your kids. Talk to your kids. If they're looking for attention, don't give them the iPad. I'm very concerned with the implications of the net in children, and some of the things that are going on now. But that's become a diversion from taking the time, because to take time with your kids is as hard as taking time with a patient. I mean, you have to be committed to do that.
Yeah, there aren't any shortcuts for
We
that,
would
right? Yeah.
we would try to eat dinner every night, even if I got home late. My kids understood that that was some time together. When they were little, they used to sleep with us because in Europe, the kids, I know a lot of parents are like, well, we don't do that. But in Europe, a lot of the kids sleep with their parents, and it's been shown. I mean, little kids, that's time with you. It may not be verbal time, but they're there physically with you. They might conk out with us, and then we'd put them in another bed later. But you know, there's little things you can do that, but you have to be consistent, and you can't, don't give them everything they want. Within reason, do the best you can, and children are smart. Don't underestimate how smart they are. They're listening to everything. They know how to play you off one another. You gotta, and you and your partner have to be on the same page in
Yeah, it's a big one.
child raising.
Got a few rapid fire questions before we close. You ready?
Are you getting ready to close?
Yeah, here we
Well,
go. Favorite restaurant in Orlando?
My kitchen.
Okay.
I
Gulf
love
of,
to cook.
all right, good. Gulf of Mexico or Gulf of America?
Jeez.
You don't have to answer that if you don't want to.
No, I'm a
All
traditionalist.
right.
Gulf of Mexico.
Old man radio question for you. Best singer songwriter: Bob Dylan, Billy Joel, Jimmy Buffett.
Songwriter,
Singer songwriter:
songwriter Bob Dylan. The singing is an acquired taste. Without question, a genius. Who were the other two? Billy Joel?
and Jimmy Buffett.
Not a Jimmy Buffett
Okay.
guy. Billy Joel. It's funny. I'll tell you a funny story.
Yep.
I was working at Riley Children's Hospital, which is a children's hospital in Indiana, and Ryan White, the poor little boy that got AIDS from transfusion was there, and all the celebrities were there, and the one that had been there the most was Elton John. I was a big Elton John fan. And my office was on the first floor. This was a hospital, it was kind of a collage of different buildings, and I got to know all the people. And one of the cleaning ladies comes, Dr. K, come on, you want to meet Elton? I said, what? He said, you want to meet Elton John? So I said, sure. So I go down, and there's a door, and then a few doors down, off a driveway was an alcove, and he was there, and he popped back into his door. So I have on my white coat like I am now, my scrubs and everything. I go up to the door, I knock on the door, and Billy and Elton John's in there with his whole entourage. I knock on the door, and I go up to him and say, hey, I'm Mike Keating. I said, I'm a huge fan. I saw you at South Bend in 1973. And he looks at his entourage and he goes, you're supposed to protect me from guys like this. And they whisked me out of there like an old drunk in a Western movie through the swinging doors. And I'm thinking, this is in his bad days. He's apologized actually for his behavior when he was having those problems. Meanwhile, about a few years later, I go down on a vacation, and we were at this some island, and Billy Joel was there. It was right after he broke up with Christy Brinkley. Well, I knew about celebrities now, and these gals I was with my wife, they all, I want to go meet Billy Joel. I said, leave the guy alone. He said, we were at St. Bart's. He said, he's here for a reason. He wants his privacy. Well, let me tell you, they wouldn't stay away. He was so gracious. He had his photographs taken with all those gals. He gave them the autographs. And I got to tell you, I wasn't a huge fan, but after that, I was a
you're
huge
now?
fan. Yes. Billy Joel, thumbs up.
Good. Greatest Notre Dame football coach ever.
Well, when I was there, it was Ara Parseghian was the coach, and he was a great coach. But I got to tell you, and I know he's quite a guy in many ways. Lou Holtz was an outstanding coach, but for historical reasons, although I never met him, probably Newt Rockne.
Yeah, you went all the way back. I figured you might. All right, your pick to win the men's NCAA basketball championship this year.
Got to tell you, I was watching Clemson last night. That's a team that has, I think, 4 or 5 players that have been there like 5 years. And they brought in a point guard from Boston College as a graduate student who's really good. I can't remember his name. And it's so funny because I was thinking about your nephew because there's this kid, he got a pass and he shoots. And I looked at it, I said, that guy's from Indiana. And sure enough, I looked it up. He's from Floyd's Knob, Indiana, 6'6", buried 4 threes. I think Clemson's a sleeper.
Hot take.
Yeah.
Heard it here first.
I think that's your team.
I love it. Mike Keating, thank you so much for being here. You're the best.
Yeah.
So appreciate it. And I've told you this so many times. I so appreciate the gift you are to our community, honestly, and to our patients here. I mean, you go above and beyond. And I hope you do figure out, even if it's just your example, how to scale you and the way you care for kids. So keep it up.
You're extremely nice, Michael. I appreciate being your guest and your friend and a colleague in care these many years. It's been my pleasure completely.
Mine as well.
Yeah.